Assalamualaikum and a very good morning to our panelists and all the students who are here today. Today we're going to give you a talk on arthroscopic all-inside ACL reconstruction technique. And the panelists involved are Dr. Fauziana and Dr. Fitri. So to start us off, Dr. Fauziana, would you like to take us away?
Okay, thank you, Mr. Ilyas. I will start sharing my screen. Okay, everyone can see my screen? So, Assalamualaikum and a very good morning. So, I'm Dr. Fauziana from Sports Team in HUKM. So, our topic for today is all-inside technique of ACL reconstruction with internal bracing. So, the tentative for today is the introduction, the case presentation, and then the knee examination and the radiological imaging will be presented by Prof. Raya. And then the intervention and lastly will be a Q&A session. So this is our patient, a 20-year-old female. She is an intercollegiate level badminton player. So the history is she had a fall which twisted her right knee on August 2020 while playing badminton. The mechanism of the injury is she pivoted her right knee in a planted foot position and then she had a pop thumb. Post-injury, she sustained immediate swelling and unable to wet bear. The swelling resolved after a week. For those of you who doesn't understand what pivoted her right knee in a planted foot position is, in a Malay term is kaki dia terkepak ke dalam atau terkepak ke luar. Okay, since the injury, she complained of pain, instability, no locking and no recurrent swelling. The instability means that she feels the knee gives way. And locking means when she flexes her knee, she's unable to straighten back to fully extend the knee. Okay, what are the most common mechanism of ACL injury? Number one is non-contact pivoting injury. Number two is knee hyperextension. And number three, awkward landing. Number four, lastly, is direct contact or collision or when the player are tackled. So what happened is, when you are tackled or when you have this non-contact pivoting injury, your what happened is when you are tackled, that the femur bone is rotated in the opposite way from the tibia bone, and then your knee goes into valgus. This is an example of what happened. As you can see, the knee is in valgus position and the tibia is in internal rotation and the foot is planted. Okay. And this is another example when the players are tackled. The knee is in valgus position and the foot is planted. This is the clinical examination of the picture, looking from the front and looking from the back. What we need to see is, number one, you see here is there is a wasting of the quadriceps muscle of the affected limb. And we need to see is there any varus or valgus alignment of the knee. And then we look at the limb from the opposite, from the side. What we need to see is any recurvatum. Why we need to see any recurvatum, I will explain in our next slide. So the summary of the clinical examination of this patient is there is a wasting of quadriceps muscles. There's minimal swelling, no effusion. There is minimal joint line tenderness, and anterior drawer test is positive grade 3. Lagman test is positive grade 2. Pivot test is also positive. McMurray and valgus varus test is negative. The Baton score is 8. I will explain the examination and how to do that in our next slide. So what is Baton score? So this is Baton score. Baton score is a scoring system developed to quantify any joint hypermobility. So 1 point is given when patient is able to bend down with the palm touching the floor. Second point is we look at the elbow joint, and there is a hyperextension of the elbow joint more than 10 degrees. And then we look at the knee joint, there is also hyperextension more than 10 degrees. And then we look at the thumb. If patient able to flexes the thumb and the thumb able to touch the forearm, that's another point. And lastly, we look at the little finger. If he or she able to flex to extend the little finger at the NCPJ joint more than 90 degrees, that's another point. So this is anterior drawer test. Okay. How to perform this test is patient will be lying supine. The knee will be flexed 90 degrees. You anchor the foot or planted the foot. And then you relaxes the hamstring muscles. Afterwards, you put your two thumbs, feel at the groove at the tibia, and then you anteriorly translate the tibia bone. Okay, this test sensitivity is 18% to 92%, and the specificity is at 78 to 98%. The sensitivity is at ranging from quite a low point of 18%, because for those who have hyperlaxity, might have an anterior drawer test positive also. Also, when patient has a deficient PCL or patient has concomitant PCL injury, the anterior drawer test might be false positive also. Second test that we need to do is Lagman test. This test also done in patient lying supine, and then the knee is flexed at 30 degrees. Okay, you can put your thigh below the patient's thigh, or your non-dominant hand holding the thigh and your dominant hand hold the tibia. And then you anteriorly translate the tibia. This test is more specific and more sensitive compared to anterior drawer test. The next test is pivot shift test. So what we are trying to demonstrate here is, as you can see, the tibia is subluxated posteriorly. So what we do is patient lies supine and patient must be completely relaxed. And then what we do is we hold the limb in full extension, we internal rotate, and we apply a valgus and axial load. And then as we flexes the knee about 20 to 30 degrees, you can see the tibia is subluxated posteriorly. This test has the highest specificity, which is at 98%. So next we do investigation is X-ray. So this is the X-ray for the patient. So these are the structures that we need to see in a VAP X-ray. We look at the femoral condyles, at the tibial plateau, at the patella, and important is we're looking at the tibial spine. So in this patient, there's no avulsion fracture of the tibial spine, and there's no avulsion fracture of the lateral aspect of tibial plateau. Why is this important? And this is an example of another patient, but I'm just putting it here. So as you can see, there is an avulsion fracture of the lateral aspect of the tibial plateau. This is called Sigon fracture. This is pathognomic for ACL injury. So we look at the lateral view of X-ray. So these are the main structures that we need to see. And for this patient, as you can see, there is no avulsion fracture of the tibial spine. Okay, and this patient had done MRI right knee in October 2020, and the further detailed MRI image interpretation will be explained by Prof. Suraya. So I'll stop sharing for a while.
Okay, wait for a second. I need to share screen. Right. Share. Okay. Assalamualaikum and good morning. Thank you for the Mr. Chairman and the Dr. Who had just presented just now. So I'm gonna talk about the imaging of this patient just now. Okay, right. As she had presented just now, I just want to touch a little bit on the X-ray of this patient. This is the right knee X-ray of the patient in AP and lateral projection. And the only positive finding that we can see is some soft tissue opacity at the suprapatellar region, which indicate that the patient has some effusion, knee effusion. And there was no fracture or any cheek fracture to suggest any avulsion fracture in this patient. So, okay. With the history of the pop sound and the clinical findings of instability, pain, locked knee, and recurrent swelling, we proceed to do MRI to assess for the cruciate ligament injury and other injuries associated with it. Okay, so just a brief thought about MRI knee. Basically, we want to do the MRI knee to assess for evidence of marrow edema or bone bruise. We want to assess the cruciate ligaments, which is the anterior and the posterior cruciate ligaments, and any associated injury, be it the meniscus or collateral ligaments or anything else that we can find in the study. Okay, so I just want to orientate you on this patient. This is a sagittal view of the right knee MRI, and this is a sagittal T2 fat saturated image. Why I say that is because the image is really dark because we are saturating all the fat that is present, and by doing that we will see if there is any abnormal fluid in the marrow, which indicate there is marrow edema. So in this patient, this is from the lateral aspect, so you can see the fibula here, and this is the tibia, and that is the lateral femoral condyle. You can start to see a hyper intense or the bright signal at the posterolateral aspect of the tibial plateau. Okay, and here as you move to the middle aspect, you can see more of the marrow edema. And this is the corresponding axial fat saturated image as well. And you can see that the marrow edema is present at the posterior aspect of both the lateral and the medial tibial condyle. Okay. All right. Okay. And those are the things. Okay. So now this is the non-fat saturated image of the patient. So normally we would do a fat saturated image and have a non-fat saturated image of the patient. So as you go, I orientate you from the medial to lateral. At the medial aspect of the tibial condyle and the medial femoral condyle, you can start to see the triangular shape structure, and this would correspond with the posterior horn of the medial meniscus. So normally the medial meniscus or the lateral meniscus would have a nice triangular structure with homogeneous hypo-intense signal. And here you can see that there is a hyper-intense signal within, and there is discontinuity of the triangular structure. So that indicates a tear. And as you go towards the intercondylar notch, you can see that this is the dark structure, which is the PCL, okay, or the posterior cruciate ligament. And if you move again towards really in the middle of the intercondylar notch, you still can't appreciate the anterior cruciate ligament at all. That is in keeping with a complete ACL structure, ACL tear. Okay, this is part of the PCL, and as I go to the lateral aspect, you can see that this is the bow tie or the triangular structure of the lateral meniscus. They are all homogeneous in signal intensity, which indicate there is no tear of the lateral meniscus. Okay, right. Okay, talk about more of the ACL. Okay, the ACL is not visualized at all in this patient. Okay, so this is the roof of the intercondylar notch, or what we call the Blumensetz line. Okay, here is where we expect the normal ACL will lie. Okay, so if there is any ACL structure, it should be of a homogeneous hypointense structure similar to the PCL. Okay, when you don't see anything, or you just see part of a fiber that is lying at the floor of the intercondylar notch, that is in keeping with a ACL stump. And this injury has been a chronic one because you don't see any fluid at all at the time of imaging. Okay. At the same time, you would want to look at the femur and the tibia. There is no other associated findings. The extensor mechanism, which is the patella tendon here, this is the patella, and this is the patella ligament. Sorry, not the patella tendon. This is the quadriceps tendon. The patella and the patella ligament here, they are all of homogeneous signal intensity and they are intact. Okay. All right. Okay. Just to show you the differentiation when the ACL is present. So the ACL would look like that. Okay. It is taut, straight, and following the Blumensetz line. Okay. And here in our patient, there is none of that visualized. Okay. This is the corresponding coronal fat saturated image. I just want to show you the image that we saw on the posterior horn of the lateral meniscus tear. So you can appreciate that there is high signal intensity, and the high signal intensity actually dissects through in a horizontal manner. So it's in keeping with the horizontal tear of the posterior meniscus. And the tear also brings about a high signal intensity posterior to it, and that is what we call the parameniscal cyst. Okay. All right. So the diagnosis in this patient would be a complete chronic ACL tear. There is no anterior tibial translation, and there is a posterior horn medial meniscus horizontal tear with parameniscal cyst formation. There is no fracture or any chondral injury demonstrated. A bit about cruciate ligament for the benefit of the medical student. The important knee stabilizers would be the anterior cruciate ligament and the posterior cruciate ligament. They are intracapsular and extrasynovial in location, and the most commonly injured is the ACL. Okay, as I showed you just now, the ACL should be a straight, taut, and the angulation should follow the roof of the intercondylar notch, or what we call the Blumensetz line. The anterior cruciate ligament is made up of two bundles. You have the anteromedial bundle and the posterolateral bundle. Okay, so that's the diagram. This is what should be seen for the anterior cruciate ligament on the coronal view, and it is made of the AM bundle and the posterolateral bundle on the coronal view, or the AP projection. And when you look at on the lateral aspect, so the AM bundle is located anteriorly, and the posterolateral bundle is located posteriorly, and they all inserts at the medial aspect of the lateral femoral condyle. Okay. So the mechanism, as what the first presenter mentioned just now, is a pivot shift and a valgus stress with internal rotation. So normally, when you are presented with an MRI image, you want to look for ACL injury. There are primary signs and secondary signs that you should look for. Okay, for primary signs, if you have an ACL, the ACL should be taut, homogeneous, hypointense anteriorly. So that actually represents the AM bundle, the anteromedial bundle. It is more hypointense, whereas the intermediate signal would be the posterolateral bundle. But it is in this manner. So if there is any laxity or any wavy appearance or any disruption of the ACL fibers with increased signal intensity of the ACL, and also if the ACL appears thickened, that would indicate there is a tear of the ACL. So then you have to think of whether it's a partial tear or a full thickness tear or a complete tear. So you have to look at the disruption of the fibers there. There are also secondary signs that you look for when there is an ACL tear. That would be if there is any anterior tibial translation, which is more than 5 mm, or a deepened femoral sulcus without a marrow edema. Okay, that is the secondary. So normally you would look at the primary signs. So the primary signs would be seen if there is an acute ACL injury. For the chronic ACL tear, you might not see the ACL at all, like what we see in our patient. So you can see either fluid filling up the space. That is what we call empty notch sign. This is at the site of the attachment at the femur, so at the medial aspect of the lateral femoral condyle. So you don't see the attachment of the ACL. Instead, you see some fluid there. So that's what we call an empty notch sign. Okay, with that, I thank you. So I stop share. And I give back to the main presenter.
Thank you, Prof. Suraya, for presenting us the MRI image interpretation. So with that, we made our diagnosis that this patient has a complete tear of her ACL ligament. So what are the management of acute ACL injuries? So what we usually do is we suggest of rest, ice, compression, and elevation. And then we ask them to do physiotherapy. The aim of physiotherapy in acute setting is to maintain the full range of motion of the affected knee and to maintain the strength of the quadriceps muscles. So these three are the exercises that we can do during the acute setting of ACL injury. Number one is static quadriceps exercise, straight leg raise exercise, and stretching. The explanation for these exercises I will present again at the end of my slides. So these are the algorithm for the patient who you suspect have an ACL tear. So number one, we see whether this patient has any concomitant injuries or not. For example, medial collateral ligament or lateral collateral ligament tear, or the patient has a repairable meniscus tear. If the patient has this concomitant injury, then we proceed for ACL reconstruction. If they does not have this injury and only have an isolated ACL tear, then we look at their athletic level. If the patient is an athlete, which is they are playing any sports at the competitive level, pro, college, or at high school, then we proceed with ACL reconstruction. If they are playing any sports at recreational level only, then we look at the IKDC activity level. IKDC activity level of strenuous or moderate, such as they are playing any sports that involve pivoting, running, jumping, then we suggest for ACL reconstruction. But if they are playing the sports only for recreational, but the activities are light and sedentary, then we consider non-operative or rehab only for the patient. So for the patient, she's an athlete who plays badminton at a collegiate level, so we proceeded with ACL reconstruction. But what we did is an all-inside ACL reconstruction with internal bracing. So for that, we need to know the knee surface anatomy. So when we look at the patient knees, we usually will draw the landmarks first. So this is the landmark of the patella tendon, and the tibia and the tibial tuberosity. and this is the pes anserinus. So we did the operation via arthroscopy. So for that, we need to make a portal. So this is the lateral portal, which is at the infrapatellar region at the lateral, and this is the infrapatellar medial portal. So the lateral portal is usually the viewing portal. What does it mean by viewing portal is we put inside our arthroscope with the camera, with the light source, and with the water irrigation system. And the medial portal is usually for as a working portal where we put in our instrument, our shaver, our diathermy. So these are the structures that we need to see when we do an arthroscopic surgery. So number one, obviously we can see the bone. This is the femur bone and this is the tibia bone. What we need to see at the bone is we look at the chondral surface. We look at the cartilage. Is there any cartilage defect? Is there any chondral injury? Is there any bruises? And then we look at the tibia chondral surface. And then we look at the meniscus. We look at the medial meniscus and at the lateral meniscus. Then we look at obviously at the ligaments. We look at the ACL and at the PCL. So this is the arthroscopic findings for our patient. As you can see here at the yellow arrow, this is the ACL, and it is completely torn from the femoral attachment site. So the ACL is fully torn at the femoral attachment. So when I'll get back to mine. So usually when we have a complete ACL tear, there's the option whether you can repair or reconstruct. But for ACL injuries, there's no option for ACL primary repair. Meaning kita ambil the end yang tercabut ni and then pasang balik. No, everything will be reconstructed. Meaning we put in a new graft. So for graft selection, there are actually 3 options for graft. One is autograft, second is allograft, and number 3 is synthetic graft. But synthetic graft is not even included here in this slide because it is totally out of option because the risk of failure rate is very high. So what does it mean by auto and what does it mean by allograft? Autograft means it is taken from your own body. It is your own self-tissue. By allograft means it is from other people punya tissue. So the autograft came from your own self-tissue. It is readily available and you won't get any immune response. There's no disease transmission, but there will be donor mobility. But for allograft, it is more expensive. It will be easier for the surgeons. It will be faster also, but the strength of the graft is significantly weaker than the autograft because when we take the allograft, we need to cure the graft by irradiation. So these are the 3 types of autograft that commonly used in ACL reconstruction. Number 1 is hamstring tendon graft. Number 2 is patella tendon graft or called bone patella tendon bone, BPTB graft. And number 3 is quadriceps patella bone autograft. Usually we use these 2 grafts, hamstring tendon or patella tendon graft. Each graft has their own pros and cons and it's up to the surgeons. So for this patient, we use hamstring graft. So how do we harvest the hamstring graft? We make a small incision at the medial side near the pes anserinus. Yeah. When you make the incision, you need to be aware of this nerve, which is called infrapatellar branch of saphenous nerve. If you injure this nerve, patient will complain of numbness at this area. Okay, afterwards, we harvest the semitendinosus and the gracilis tendon. Why we take these 2 tendons is because these 2 tendons are long, tubular, and expandable. Okay, when we harvest this graft, as you can see, this is the vincula. Vincula is the blood supply to the tendon. So when we take the graft, we need to ligate this. So this is the example of picture of a harvested hamstring graft. As you can see, it is long and it is tubular. Okay, this is what we call the internal bracing. We put in a one fiber tape, which is about 18 centimeters long. This tape is used to augment the hamstring graft, to strengthen it. So what we did is we fold the tape and we fold the hamstring graft around the tape. And this is the final result, the images of the graft prepared to be inserted into the patient's leg. So this is the two picture of a conventional ACL recon, and this is the all inside with internal bracing ACL recon. We first look at the conventional ACL recon. So for conventional ACL recon, you need to drill a tunnel, a transtibial tunnel, from here from outside to inside, and we drill a tunnel from outside to inside at the femur bone also. And then we need to pass the graft from outside and bring it up here. And we anchor the graft in the bone using two screws. Okay, there are many options available of implant on how to anchor this graft. You can use a bioabsorbable screw, you can use an interference screw, you can use endo button, and then for all inside internal bracing ACL recon, what we did is, number one, we did not drill a whole tunnel here, but what we did is we drill a socket using a reversible drill. So sikit je kita akan drill kat sini, and kat femur bone sikit saja. And then the graft is significantly shorter compared to the graft that we need in conventional ACL recon. So these are the images of the chest X-ray post-operation. So for post-operative rehabilitation for patients and what ACL recon, we divided the phase into 3 phases: acute phase, recovery phase, and functional phase. So in acute phase, the aim first is to control pain, swelling, and inflammation. These are the most important things that we need to emphasize. And number 2, the aim is to regain back the muscle strength. 3, to restore back the range of motion. And number 4, to ambulate them safely using the crutches while protecting the graft. So what we give to them is, number 1 is analgesia. This is to reduce the pain and to reduce the inflammation. We can give them NSAIDs, non-steroidal anti-inflammatory drugs. And number 2, we gave them cold compression therapy using a game ready or cryo cuff. So what is game ready? Game ready is a machine that we put an ice inside, and then we put a cuff surrounding the patient's leg. So what it gives is, it gives a continuous cooling effect at a therapeutic temperature, which is at 2 to 10 degrees. This is the most effective temperature that promotes healing. Number 2, it reduces the swelling by providing an intermittent compression, and it reduces the pain and the muscle spasm. Then post-op, we need to teach them physiotherapy. Physiotherapy is very important in ACL reconstruction patient. Number 1, we need to emphasize on the passive knee extension. This is to get back the knee range motion. How do we do this? Number 1, you can ask the patient, you can instruct the patient to put a pillow or selimut behind the heel for them to get their legs straight, extended like this. Or patient can lie prone and you can get the full extension. Second, we can teach them static quadriceps exercise, where patient lies down like this and they contract their quadriceps muscles. This is to get back the muscle strengthening. This is a strengthening exercise, same as SLR. This is straight leg raising exercises. You can do it active, like macam tu je, or you can use a band, elastic band. This is a passive SLR. This is to strengthen your muscle. And this is ankle foot pump exercise, where we ask patient to fully dorsiflex the ankle and plantarflex the ankle. This is to these exercises is promoted to prevent DVT. And we need to teach them a patella mobility exercise. We ask them to feel the patella and move them medially, laterally, superiorly, and inferiorly. And we teach them to do heel slide exercise. Number 4, we need to put them on knee brace. So this is an example of the knee brace that we usually use in our setting. So this is post-op knee brace or T-ROM brace. They need to wear this brace at least 24/7. This is used in 0-degree lock-in extension. They need to wear it at all times when they are walking. This is to protect the graft. And lastly, we ask them to do a non-weight-bearing crutches. This is also to protect the graft. So next, the recovery phase at 3 to 6 weeks. The aim is to improve the muscle strength and for the muscle endurance. And we need to improve the functional stability. For that, the physiotherapist will teach the patient to do a gait training, quadriceps muscle strengthening, a closed chain exercises such as wall squats and stationary cycling. A closed chain exercise means the terminal end is fixated. For example, the foot is fixated at the floor. So when patient bend down, there will be co-contraction of the hamstring muscle of the quadriceps. And this is example of stationary cycling. And they still need to wear their knee brace, but we allow them to slowly walk with a full weight bearing, but with the knee brace. So at the functional phase at 6 to 12 weeks, the aim is to get them to return to the previous level of activities and to prevent any re-injuries while doing this. So for that, we teach them to do a dynamic balance training. For example, patient will stand on a silicone ball and they need to balance themselves. And then we can start off the brace, and the patient can start small functional exercises such as brisk walking, light jogging, and running after 12 weeks. And they can start doing open chain exercises. That's it from my side. Mr. Ilyas.
Thank you, Farzana. So our take-home message today is ACL injuries cannot heal spontaneously to the functional capacity. Not all ACL injuries need to be reconstructed. ACL reconstruction surgery is a soft tissue surgery, and rehabilitation is equally important as the surgery itself. Now, I'd like to express my gratitude to Prof. Suraya, Dr. Faziana, and the rest of the Auto Sports team, Dr. Wadrul, Mr. Farihan, Dr. Leila, and Mr. Kabela, and the rest of the team who have worked tirelessly to complete this CPC. And last but not least, our Encik Buhari for organizing everything and sorting this out. Okay, thank you very much, and I hope everybody's taken something away from this today. Right after this, there's going to be a Kahoot quiz, and after that, there'll be the CPD points being put up on screen. Okay, thank you.
Okay, thank you, Doktor. Congratulations. Saya akan sharekan slide untuk Kahoot. Okay, quiz Kahoot ini untuk medical student, sila gunakan nombor metrik anda. Quiz Kahoot ini untuk medical student dan mereka akan menggunakan nombor metrik. Terima kasih. Okey, untuk kaki tangan saya dah sharekan link pada ruangan komen. Okey, dekat FB pun sama. Sekejap lagi saya akan sharekan link dekat ruangan komen. Silakan kalau ada admin lain di sini untuk tolong share di FB. Okey, link di ruangan komen boleh juga untuk share di FB. Untuk barcode ni untuk doktor sahaja. CPD point menggunakan MMA apps. Okey, untuk doktor sahaja. Untuk kaki tangan, sila klik link yang saya share di ruangan komen. Terima kasih.